Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. wildhealth.com for all the information on becoming a patient or working with us.
Thanks so much for listening to the Wild Health Podcast. If you're a Wild Health patient, you might not know, but you have access to our referral program. This gets your friends and family 25% off Wild Health services. Just head to Clarity, and in the top right corner, you'll see Refer a Friend. Click there, and you'll be brought to a page with your referral code. Happy sharing. Really excited to have Dr. Carla DiGirolamo with us today. Introducing Carla would take a podcast of its own, but I'll do my best to do it quickly. She's a double board certified obstetrician gynecologist and reproductive endocrinologist who specializes in the care of reproductive age and midlife women. Carla completed her training in residency at Brown University and then her reproductive endocrinology fellowship at the Massachusetts General Hospital at Harvard Medical School. She is North American Menopause Society certified menopause practitioner. She's been featured in multiple podcasts and speakerships at various events. Carla's also been in the fitness industry her entire life as a recreational athlete and in the last decade as a fitness professional with credentials as a CrossFit Level 1 trainer and certified nutrition coach. Currently a partner physician at Boston IVF in Waltham, Massachusetts, with over 17 years of experience practicing as a fertility specialist and more recently as a menopause health consultant. Featured in Boston Magazine's Top Doctors, 5+ times. If you want to learn more about Carla after the podcast, www.drcarlad.com. That's www.drcarlad.com. And now on to the podcast. All right. Dr. DiGirolamo. Did I even come close, Carla, to getting that right?
You did. You actually pronounced it the way the Europeans do.
I'm
The
so
American,
cultured.
yeah, you are. The American pronunciation is DiGirolamo, but all of my friends from Brazil and from Europe, it's DiGirolamo, and I love the way they say it. I wish that that was the American pronunciation, but I will go by either.
Okay. All right. Well, I like to go by Mike, and I know you like to go by Carla anyway. So
Yes,
I'm really
absolutely.
excited to get a chance to chat with you here. I just came back from Central America, so maybe that's why I pronounced it that way. I'm not sure. Maybe it just rubbed off on me. All right. Well, we have had so many questions over the years come in to us as physicians, as health coaches. We've had questions come in through the podcast around weight loss or weight gain and the role that female hormones can play in the process of either unintendedly gaining weight or having difficulty losing weight. And with your background, which listeners just got to hear about, we thought nobody would be better to come on and give us really simple answers to these simple questions, right? These are like super straightforward and easy fixes.
Yeah, I wish that were the case, but we will boil it down as best we can to make it understandable.
All right, let's launch right in. So why don't we just start really broadly? What role do female hormones play in weight gain and weight loss for women?
You know, when we think about hormones, it's they're not in silos. There aren't like hormones for weight loss and hormones for this, that, or the other process. The hormone system is like a big orchestra, and it all works together. The trumpet section doesn't function independently of the woodwinds and the bass. They all work together. So it's kind of hard to parse it out. So when you're thinking about, well, why is a woman gaining weight? The obvious things are, you take a look at, well, what is her balance of activity versus the fuel that she's taking in? That's the first thing you look at. Has that changed? You want to also look at any medical conditions. Does she have a thyroid disorder? This may not have anything to do with female hormones. May just have to do with regular old hormones that men and women both have. So, you kind of got to go through all of that and figure out, well, why is she gaining weight? And some of the things, like once you rule all that out and everything looks good, the next thing you want to look at is her stress response. For women, the stress response, the fight or flight pathway, is so integrally related to her reproductive system. And this is why women deal with the stress response much differently from men, because what happens is when the stress response is activated, especially for a prolonged period of time, it is designed by evolution to turn off or suppress the reproductive system. Because you think about it, if there's a bear in the woods waiting to eat you, it's not a good time to be getting pregnant. So Mother Nature kind of incorporated that in to perpetuate the species, promote survival and procreation. And so stress plays a very, very different role in women as opposed to men. And one of the manifestations of this that we sometimes see is weight gain. And what happens is if the body is perceiving a stress, like say you have an athlete who is overtraining and underfueling, or it could even be somebody who's not an athlete, but maybe they have anorexia and, they have a psychiatric component to it. The stress response is seeing that as a bear in the woods, or it thinks there's a famine coming. So if the system thinks there's a famine coming, it's going to regulate the thyroid and every other metabolic process to hold on to fat, hold on to fuel, and that's going to make weight loss very, very difficult. So when I see clients or patients, athletes or patients, and they're complaining of this, and I've excluded every other disease, and, the whole fueling and energy balance situation. I then start to look at stress and say, what's happening there? Because the body just might be sensing, oh my God, there's something bad happening. We're going to hunker down. So as a general rule, those are some of the components of how I address weight gain in women.
I love that. And, looking at the obvious causes first, I think if we could all just remember to think of the thyroid once a day, we'd probably be better clinicians as a whole.
Sure.
Let's say that you're working with someone and they, you've kind of done that. There haven't been significant nutritional changes. They haven't had a significant change to their training routines. They're sleeping pretty well. They seem like they're feeling okay. How can a woman determine if she has a hormonal imbalance that's affecting their weight?
Well, the first thing you look at is the female vital sign, which is the menstrual cycle. That's the beauty of female physiology, is that there is a direct thing that is measurable and trackable that is a direct reflection of her physiology. Men are a bit more of a mystery because they don't have a menstrual cycle. So there could be stuff going on and it isn't necessarily quite as obvious. But with women, when things go off, the menstrual cycle is often the first thing that you'll see it in. And so if I've done all of those things that you've mentioned, then I start digging into, well, tell me about your periods. And then of course, she'll say, okay, I have a Mirena IUD, and so I don't get my periods anymore. And then you kind of have to figure out if she's cycling in any way, and there's other symptoms you can ask about, et cetera. But I look to the menstrual cycle to see, okay, what's changed. And then if something has changed, I kind of dig into, well, why is it longer, or why is it shorter? Why are you skipping periods? And oftentimes the conversation is just taken in a certain direction, depending on what she tells me.
That may be the first time anyone's ever said to me that men might be more mysterious or complicated than women, Carla.
You heard it here first from a gynecologist. So
unbelievable. I'm learning so much. All right. So, when I think of weight gain in a female patient, and again, there's so much qualifying that could be done around this, but we're talking about, in this setting, we're talking about gaining fat, not gaining muscle, lean muscle mass. And we're talking about unintended weight gain, right? So people putting on fat or having a hard time losing fat. Let's say they've really dramatically altered their lifestyle. They're, eating healthier, they're avoiding processed foods, they're working out more regularly, they've probably incorporated some resistance training to try and build some lean muscle. They're really kind of firing on a lot of cylinders, but the weight's just not coming off. We launch into a conversation with them, looking at the low-hanging fruit we already talked about, and then let's say that they are having some alteration in their cycle and we think it's stress related. Well, then we have kind of a pathway to go down. But one of the things that I feel like comes up pretty frequently is the capital M of menopause. And this is I can't say 100% certain conversation, but it is a really common conversation that comes up with female patients I'm treating who are in the perimenopausal or menopausal phase. So can you talk to us a little bit about how the changes associated with menopause affect women's hormones and may lead to difficulty losing fat mass or unintended weight gain?
Absolutely. And it's a huge, huge thing that's happening. You think about how awkward puberty was, right? When everything was turning on. It's very awkward for both men and for women. But once men go through puberty, that's it. You're kind of on that track. When women go through puberty, they get to go through it in reverse. And that is what menopause is. The turning off of the hormones is just as dramatic as the turning on of the hormones. And what happens is when the ovaries, and the hallmark of menopause is when the ovaries are creating or producing less estrogen. And, the ovaries are winding down. They're not ovulating as many eggs. And, the best supply of eggs is running out. And what goes along with that is that it produces less estrogen. And over time, it produces less testosterone and less of all of those hormones. And so when estrogen levels start to decline, and, on that tangent, I just want to be clear that in perimenopause, it is a circus. It is an absolute circus. We talk about the function of the ovaries declining, but what happens in the phase leading into menopause, which is about 4 to 6 years, more close to 6 in most women, is that it's just dysregulated, dysynchronous secretion of hormones because the ovaries just don't know what to do with this. It's just part of the transition. It's trying to figure itself out. And so you're going to have, days where you're estrogen dominant. And then like in a week, you could flip and then you could be progesterone dominant for a few days. And then the pattern is just completely chaotic. But then when menopause happens, that's when all of that chaos settles out and you hit this new normal of very low estrogen, very low progesterone. You're not ovulating anymore. Periods haven't happened for about a year. That's what the hallmark of menopause is. So what happens when you start having dysregulated estrogen signaling in the perimenopause and then finally much lower levels in the menopause is that the receptors for estrogen, for example, in muscle, start to decline. And this is probably one of the biggest metabolic issues that people don't really think about. I'll tell you, I didn't think about it until I was writing a course that I just made for MedFit classroom about menopause and physiology, is the tremendous impact of estrogen on skeletal muscle. Because skeletal muscle, it's massive. It's probably one of the biggest glucose utilizers, second only to the brain. And so when estrogen levels and receptors on the muscle start to go down, the muscle doesn't respond to it much more. So the muscle it's not as powerful. The type 2 fibers start to change to type 1 fibers. We start seeing this transition. Muscles lose power and they also lose their metabolic ability. So their ability to use glucose is also declining, which is making them more insulin resistant. And so this is one of the biggest culprits of weight gain, unintentional, despite everything we do. The big thing I hear is the things I used to do are not working anymore. And it's like, well, because your estrogen and your receptors on your muscles are just not doing what they used to do. So I would say if I were to pick one reason in perimenopause and menopause why women are gaining weight is because of skeletal muscle health. It's declining, losing power, losing mass, and that creates this insulin resistant situation.
Wow, that you just taught me that, and I think that's phenomenal. And thank you for that, because we talk frequently with folks who have insulin resistance, whether it's high fasting insulin or full on prediabetes or diabetes. And one of the strategies that we know works tremendously well is to increase lean muscle mass. just because of the reasons you're alluding to. That muscle is really a metabolic sink. It's a wonderful place to make ourselves insulin sensitive and to drive the appropriate utilization of glucose. If you're just not responding to that metabolic signal the same way because your estrogen levels have dropped, it's, of course, you're doing the same amount of work, but you're not seeing the same results, and you're having a hard time holding on to lean muscle, and as a result, you're likely going to be more prone to gaining fat mass. I think it's a clear segue into the role of hormonal replacement therapy. But before we jump to that, let's say somebody's like, heck no, I won't go. I'm not going to do hormonal replacement therapy, or even more so, they have a strong contraindication for some reason to starting HRT. Are there ways to naturally increase estrogen in the perimenopausal, menopausal period that could combat some of the effects that we're seeing with regards to skeletal health?
Well, it's really, yes, it's an issue with the estrogen, but nature has programmed that decline in estrogen at this time of life for a reason. And when we try to recreate the hormone environment at 30, when you're 50, 55, 60, 65, it can't be done because all of the regulatory mechanisms at the hormone secretion level and at the receptor level cannot be replicated by a estradiol patch or any other form. It just can't be. And it's not so much about the levels that are creating the issues. It's that whole regulatory dynamic that has changed. Now,
gotcha. So instead of, oh, sorry, Carla, I just want to make sure I'm getting this right. So basically, the follicle stimulating hormone, luteinizing hormone, estrogen, progesterone, this complex orchestra, which I thought was just a phenomenal analogy or metaphor. I never know which one's which. My mother, who's an English teacher, is probably going to be very disappointed if she hears this. But giving hormone replacement therapy is kind of like, here's the saxophones and the trombones, but we're not giving you back the rest of the orchestra. So of course it's not going to work as well as our endogenous system.
Right, and plus to go forward with the metaphor / analogy, it's that here are the saxophones. You're just going to blow into it, and you're going to blow the same note, and it's going to go up, and it's going to go down. So it's really a great analogy because that's really what just adding hormones back does, is that you're really adding some hormone, and it can do a lot of good. It can help with hot flashes. It helps with vaginal dryness and some of the urinary genital system symptoms that women have during menopause. It's great. It's a great treatment of symptoms. But I think the biggest mistake that providers and patients taking these medications think is that these magic pills can recreate the hormone environment that existed in their reproductive years, and that just doesn't happen. And so the answer really isn't hormone therapy. And we've moved away from calling it replacement because in menopause, you're not replacing something that is, it's not supposed to be there in menopause. So you're not replacing something because it's not supposed to be there, because really we don't want to, and we can't reproduce the 30-year-old paradigm, because that just doesn't work as we get older, because it causes problems with blood clots. It could potentially cause problems with cancer. So there's reasons why nature did this, but we just have to kind of understand that and work within it. So really, the single best way to promote muscular health is to start lifting heavy stuff. There's no better time to get into Olympic weight training. And then, of course, you hear everybody in the audience right now. I can hear them shrieking, "Oh my God, she wants my 60-year-old mother to do Olympic weightlifting." Well, obviously you do it with a coach. I wouldn't want her to go out running on her own unless maybe she had some supervision, if she'd never done it before, like anything else. But you got to start stimulating those muscles, because the estrogen stimulation is gone. Go out, do yard work, learn how to do deadlifts, learn how to do back squats and front squats. You don't have to be doing snatches, but just some basic, weightlifting that one can be done safely, that is going to really stimulate those muscles. And you got to fuel those muscles. Protein's the other half the story. And, because it's a very catabolic time of our lives. Our bone, we're losing bone mass in menopause. We're losing muscle mass. So you have to exercise and do the muscle building and the weight bearing and the plyometrics for the bones as well. But you got to fuel that as well. And those are the strategies that are going to help with increasing metabolic rate, because you're going to keep her muscle mass if she does those things. And hormone therapy isn't going to do any of that. Hormone therapy does not treat that muscle mass. It doesn't change body composition. The thought is that if you start hormone therapy for, say, hot flashes early on in menopause, you might attenuate this, you might like just prolong the inevitable, but eventually after a couple of years, the body kicks in, because again, you're not recreating that hormonal environment. So really the best way around weight loss is not through hormone therapy. It's actually through, rolling up your sleeves and getting down and dirty and doing the heavy lifting and, the HIIT training and all of those things that keep you strong and keep you healthy.
As much as an easy fix, like, adding a supplement or adding a prescription medication to your regimen might be attractive, it turns out that good old-fashioned weightlifting gets you what you need to get. Certainly I have family members who are dealing with osteoporosis and do not have a history of resistance training. And if I can, in retrospect, if I could advise one thing, it would have been to start learning some basic resistance training practices. And even if it is, as you say, just a deadlift, right? I mean, it's something to bear heavy weight with your bones. Yes, if there's more variety, you're probably able to do it more often. And certainly doing it with proper supervision when you don't know the movements is critical, or else you end up with the weight gain issues that you're working with, and then also a herniated disc because you had bad form when you were working on learning how to deadlift. So couldn't agree more. I think proper training and supervision as you're getting started is really critical. But it sounds like lift heavy weights is the take-home message for maintaining and building lean muscle mass. And we know that if you look across the American population, that women over the age of 50 have very low on average protein intake, and that resistance training, while I feel like that's changed in the last 10 years and become something where we see a lot more women doing resistance training, both at the gym and CrossFit, etc. But women who are in their 50s and 60s and 70s, that really wasn't as culturally popular at the time. So I feel like there's a lot of room to improve the adoption of resistance training in that population.
Oh, for sure. I mean, I'm in that population myself. I'm 52, and I started training in the gym when I was 15. My father was a semi-pro football player, and he wasn't a very big individual, and neither am I. And he's like, look, you got to compensate for your size. You got to go into the gym and you got to train. Because I was an athlete when I was very young. He said, that's what you got to do. And I was like the only one there who was 15 years old, female, back in the 1980s. And so it comes from there. It's like you were kind of an outcast if you did this. And, but I did it anyway because my father was an athlete and that was the right thing to do. And thank God, he got me doing it at an early age. But that's not the case for most of us in this generation. So, yeah, there are many women in my age group who are out there running. They're doing a lot of endurance stuff, which is great. But you need to round out the fitness. You need to have a variety if you're going to keep the muscle stimulated, for sure.
Yeah. And I mean, you can, fastest growing sport in America, pickleball, super popular with folks, in the 50 to 70 age range. But ultimately really kind of more of a catabolic sport. Right. I mean, it's endurance and you get your heart rate up and it's some cardio, but there's really nothing in the way of resistance that's happening there. So
there isn't, except for bones. It is good for the bones because you've got changing directional stimulation of the bones. So it's more of a plyometric than it is anything else. And plyometrics are important for any program, but you got to mix it in with the other things for sure.
All right. I want to, I have a personal mission to kind of aim for 20 to 30 minutes on podcasts, even though I feel like we could go way deeper on this one topic. I'm going to try and take us home with a related but different topic, which is something that comes up all the time with female patients I'm working with who are considering oral contraception or alternative forms of contraception and are concerned about the effect that contraceptive methods have on hormones and weight gain.
Are we
So would
talking
love
about
to
reproducctive age women, or are we talking about
reproductive
perimenopausal
age
women?
women. Yeah, so
Age women,
reproductive
yeah.
age women. So
Mhm.
I think if you want to add your take on sort of perimenopausal women or even menopausal women and concerns around weight gain with contraceptive therapy, I'd love to hear that too. But this is
Mhm.
the reproductive age woman who, for whatever reason, somebody told her she should go on to oral contraceptive, maybe irregular menses or whatever other issues are going on. That's the number one concern that I hear from that patient
Mhm.
population is this going to make me gain a lot of weight? So I'd love to hear just sort of how you approach those conversations and what your thoughts are.
There are so many different types of hormonal contraception out there, and some of them have more propensity for weight gain than others. I think the Depo-Provera shot, which is progesterone alone, that probably has the highest incidence of weight gain as compared to any other hormonal contraception. So, I mean, women typically don't like those, but it is very cheap. You just get one. You don't have to remember to take a pill every day. There are some attractive things about it, but from a weight gain standpoint, Depo-Provera is probably the one that's going to give people the most trouble. There are certain individuals who may have a propensity to weight gain than others, like a lot of people who I've seen as a fertility expert who have polycystic ovarian syndrome, which is a syndrome where you don't have regular periods due to dysregulated male hormone production in the body. They tend to be a little bit more sensitive to birth control pills. I get more complaints from them saying, yeah, I went on the pill to regulate my periods and I gained all this weight. Typically, if you consider the population as a whole, not just people with PCOS, but if you consider reproductive age women as a whole, the birth control pill does not usually cause weight gain in most people. And the doses these days are so low that it's usually not an issue. But if you have athletes who are competitive, the birth control pill can potentially impact performance because when the menstrual cycle is cycling normally, there are opportunities for training in certain ways, depending on the phase of the menstrual cycle you're in, that can really maximize your performance. And that is a whole other 30-minute podcast that we can do sometime. But if you have athletes, my preferred birth control for an athlete who's really concerned about getting the edge in performance is a progesterone IUD. And there are lots of different sizes, lots of different doses. That's the best one, I think, for maintaining performance. It's also incredibly effective, and you can put it in and forget about it. So pills don't impact most people, but some people it can. Injectable progesterone like Depo-Provera, probably the one that's most associated with weight gain. But my favorite is the progesterone IUD. That's not usually associated with any weight gain, and it really helps people maintain their cycles so that they can perform better.
I love that. Absolute pearls of wisdom. And I am going to take you up on your offer. We'll definitely spend another episode chatting about opportunities for optimizing performance by timing interventions around different parts of the menstrual cycle. So I think that people would really enjoy that as well. Carla, I always feel like I learn stuff when we chat, and just love hanging out with you. And you bring me back to my my time in Boston. Just knowing that you're there and just your twinge of a Boston accent. You don't really.
Oh, it's just a twinge,
It's
really?
just a twinge. I mean, come
Wow.
on. You know somebody. You know a lot of people with a lot stronger Boston accent than you have.
Well, I'll tell you, my friends in Philadelphia beat it out of me when I went to medical school. That's where I
Oh,
started
that's
med
what it
school,
was.
and because they couldn't understand me. And then I went down south and I finished up my medical school down there, and they really couldn't understand me. So I had to lose the Boston accent a little bit, but it never goes away completely, especially when I still live here. So.
Yeah, well, that's the
But
thing. It's what has it been, about 8 years since I lived there? But every time I don't shovel my driveway, I think, okay, I don't miss Boston in
right.
January, but it's such a fun town and so many other attractions. Awesome. Well, thank you so much. We'll connect off the podcast with our schedules and come up with another time to chat. But really appreciate you.
All right, sounds good, Mike. Thanks so much.
Thank you.
Everybody, a quick note about our precision medicine training program. It's been a really popular course. We're constantly hiring health coaches and physicians, but we're only hiring them as we grow if they're trained in precision medicine. You don't get that in medical school or other places. And so we've developed this training program, and we've completely revamped it recently. It's a lot more robust. So now there's still over 50 hours of live synchronous training. There's also all the asynchronous credit, over 50 hours of content. And as a physician, you get about 50 hours of AMA Category 1 CME credit, which is a nice benefit. For the health coaches going through the training program, it's now accredited by the National Board of Health and Wellness Coaching. So graduates are going to meet the requirement to sit for the board exam and become board certified health coaches. So there's a lot of benefits to that, not just the certification, but also when it comes to things like insurance reimbursement. So it's a really robust program. If you're a physician, a nurse practitioner, a PA, or someone that just wants to be a health coach, it's open to all of those categories. There's the 6-month program that's kind of the full program. And then we also have just a fundamentals of precision medicine course, which is completely on your own. It's online. It's all asynchronous. You still get the 50 hours of AMA Category 1, but it's self-paced, and you still have access to the online community, but not all the synchronous lectures as well. So if you're interested in checking that out, go to wildhealth.com/education, and we'd love to have you as part of our next class.